this fine early Friday morning. Welcome back to class. Thank God it's Friday. You made it through another week. Let's get it wrapped up. All right, so we are getting to the end of our chapter here on non-aseptic techniques on chapter 19. We don't have very much further to go, so I don't anticipate it taking the entire class period to finish this today, which will give you guys some extra study time for your upcoming tests. Let's get to it. Wrap this chapter up. Okay, so we left off last time talking a little bit about barium enemas and the procedure of prepping our patients. And that's what this slide here is detailing, just some of the prep that goes into getting ready for that barium enema procedure. Because one key aspect of barium enema is before we can actually perform that exam, patient's colon or large intestine needs to be completely cleared out. In other words, we can't have any fecal material in that colon, because if there is, it's actually going to interfere with the study. So we want them to be completely cleaned out. So how do we achieve that? Well, they have a set of instructions right here that they must follow very, very strictly to make sure that that colon is properly cleaned out. Now, if they do come to the hospital for their exam and they did not follow these instructions, that's the reason we do what's called a scalp image to start the process. So anytime you do a barium enema procedure, really any fluoro that you're ever going to do, you're going to do a scalp film just to make sure everything looks nice and clear on the patient's insides before we proceed with the exam. Because if we were to proceed with the exam without doing that scalp and there was fecal material, it's going to mess up the whole study. So in that case, if someone didn't follow these instructions properly or they told a lie, they didn't really tell the truth at all, they'd actually send that patient back home and they'd have to start all the way back over again. And if any of you have ever done bowel prep before, that's something you don't want to start over again because it's not the most fun experience. So what's that entail? You're going to have a person start eating a light meal 2 days before their exam. That's to make sure there's no heavy accumulation of feces within the large intestine. And the day before the exam, they're going to do almost a completely liquid meal because liquids are acceptable. They don't want you drinking heavy liquids. Like water is very acceptable. Just having something like chicken broth for dinner would be okay. The main point is you're just going to be on liquids. That way you're not accumulating feces within the colon. And then what they do a lot these days, you see where it's saying clear liquid, clear liquid, clear liquid, clear liquid. Most of the time, you're also going to be given a substance called Go Lightly. Go Lightly is a bowel cleanser. And the day before the exam, you're going to take this bowel cleanser. It's going to have the instructions on the bottle. You're going to drink it throughout the day. And it's going to make you go to the bathroom a lot. It's going to clean you out. And I always laugh because they call that brand of bowel cleanser Go Lightly. I always say it's the most deceptive classification for a product because there's nothing light about going when you're taking that product. I mean, you're going heavy. I say they should change the product name to Go Heavy because you go like crazy. And I've had a colonoscopy done before. I've had to take that stuff, and there's nothing light about it. I mean, there's nothing light about that product. I mean, it cleans you out really fast. You have to live by the bathroom for the whole day to put it into perspective. So you will have to have that, and that's, once again, the purpose of cleaning you out, cleaning out your intestinal tract. That way, nothing's going to interfere with that exam or procedure. And then sometimes, depending on where you go, you see at the very bottom there, day of the exam, morning of the exam. Of course, you're not supposed to eat anything after midnight or drink anything. You're going to be NPO for at least 8 hours, which means nothing by mouth for 8 hours. That's very important. But some facilities will require the patient to do an actual enema before the exam. That's not a very common practice these days anymore. Most of the time, you're going to be doing that Go Lightly substance that I just talked about, and you're going to be prepped beforehand. You're not going to have to worry about doing that enema before. But should a patient show up to the hospital and they still need to get that procedure done, they have the option of a applying an actual enema to clean them out there at the hospital. But once again, that's a very rare thing. That doesn't happen very much anymore. That would be a last resort if they just really need to get that exam done and that patient didn't follow the instructions properly. So a lot of prep for that one exam, and it has to be followed very strictly, or they're going to have to most of the time just reschedule the entire thing all over again. All right, so who's going to perform this exam? Of course, the radiologist, sometimes the radiologist assistant as well. That's an RA, something that you guys can go to school for, by the way. That's like a radiologist practitioner, like a nurse practitioner, but on the radiologist side. And that barium, of course, is going to be inserted through the tip of the through a tip in the rectum. It's going to fill the colon in what we call a retrograde fashion. It's going to go in reverse. Remember, we don't actually drink the barium. We're administering it through the rectum. It's going backwards through that digestive tract to fill up that entire colon. Now, if the patient does have a suspicion of a perforated bowel, which would be like a hole in the intestinal wall, to put that simply, they're not going to use barium because that could actually cause a lot of damage, a lot of infection. They're going to opt for what we call water-soluble iodine. Water-soluble iodine, not the preferred contrast medium, but for the patient's safety, if they are presenting with a perforated bowel, they would opt for that instead of that actual barium sulfate. But do remember that that colon is being filled in what we call a retrograde fashion. And that's what a perforated bowel looks like, by the way, guys. Not the prettiest picture there, but it literally is a hole inside the intestinal wall. And that's why we wouldn't opt for that barium sulfate. If we were administering that barium sulfate, of course, it's going to leach out to get into the surrounding cavities and cause a lot of issues inside the patient. That's why we would use that water-soluble iodine. If it did leak out, it's not going to cause the damage. It's going to actually be absorbed by the body more naturally. It'd be a lot safer option overall, while still lighting up the colon and letting us see what's going on. Of course, there's some of our anatomy. You guys remember that from last semester. Don't forget that anatomy, by the way, because a year from now, when you're in Rad Pro 4, we're going to revisit all this quite a bit. We're going to be even more detailed with it. Of course, that would be a barium enema study, what it should look like. Remember, if we're following the path of how it's administered, we're starting at the rectum down here. We're going to let that barium flow in. It's going to go backwards through the sigmoid, descending, flexure, transverse, the right collic flexure, ascending all the way to the cecum. And what the doctor or radiologist is always looking for is for that barium to reach the cecum and start going back through the ileocecal valve. Now, if you remember, the ileocecal valve is the connection point where the small intestine ends and dumps its contents into the large intestine. Once barium reaches the ileocecal valve, the study is complete. Study is complete. That is what the doctor is looking for. In fact, they'll actually do what's called a spot film of that ileocecal valve. It'll be a magnified view of that actual piece of anatomy just to confirm that the barium has reached that point and it's flowing properly backwards into that small intestine. And we can go ahead and end that exam and drain that barium out of the patient and let them go along their fine way. Okay, so for that barium as a contrast agent, why do we use barium sulfate? The primary reason we use that barium sulfate is it contains what we call a high atomic number. And the higher the atomic number is on an element, the more optimum the contrast is going to be. In other words, it's going to light up that colon even better. If we use a low atomic number, we're not going to visualize it very well. So we opt for those high atomic numbers, and barium sulfate contains what we call a high atomic number. It's going to be a very dense substance to really light up that colon and attenuate those x-rays properly. So sometimes it's pre-mixed. In fact, most of them these days are pre-mixed. They're going to come in these bottles you see like here on the right. You can just pour it into the barium bag. But sometimes it'll be a powder, and there's going to be instructions of how to mix it with water to get your consistency and get the correct amounts. And typically you're going to use about 3,000 milliliters of barium on a patient, which is quite a bit. It's quite a bit, but the colon does hold a lot of liquid. Some other reasons we're going to use that barium sulfate specifically, preferably, is going to allow for rapid flow. Even though it's a high atomic number, it flows quite easily. It's not an extremely thick substance. It's going to adhere to the mucosa very well. In other words, it's going to coat the walls of that intestine very, very well so we can see that entire colon lit up properly. And it's going to provide the adequate radiographic density in a thin layer. Once again, it's applying that high atomic number to provide that proper density and show the anatomy properly. And it's going to lack foam or artifacts. Some contrast mediums can actually foam up, like actual foam, and some can actually leave very prominent artifacts. And that barium sulfate is not going to do that. That's why it's that preferred choice. So, funny story, when I was in school, one of my classmates, God bless her soul, she was just hilarious. She was always a bit of a klutz, and she was getting ready to do an upper GI, and she accidentally grabbed the barium enema barium for the upper GI, and she had it poured in the cup and ready to go. She was going to have the patient drink barium enema contrast, which really is kind of the same thing as an upper GI, it's just a little bit different consistency. So it wasn't going to hurt the patient, but we really messed with her and had a big laugh that she was about to have the patient drink BE juice. So I remember that happening. That was like my third semester in x-ray school. We never let her live that down. She was giving her patient some BE juice to drink that morning. But it would not hurt the patient, actually. It just wouldn't have the correct consistency for the stomach because there are different thicknesses and consistencies amongst those barium sulfate solutions. So the barium for the BE is going to be a little bit of a different consistency compared to the upper GI and esophageal, even though it's the same kind of substance, barium sulfate suspension. And here's what your contrast kits would look like, guys. On the left there is what we call a single contrast kit. On the right is a double contrast kit. Now, when you see the word single contrast, that simply means we're only letting barium flow into the colon. That's all it's going in. If you see the word double contrast, that means alongside the barium going into the patient's large intestine, the doctor's also pumping air into the colon. That's where that double contrast comes from, because air is considered a contrast medium as well. And the point of the double contrast would be a better visualization of the inside walls of the large intestine. So if that patient has a suspicion of polyps and they can't get a colonoscopy, they would do that double contrast barium enema study, because with the air added to the barium, it's really going to light up the inside of that colon properly, and you'll be able to see those polyps very clearly with the air. If it was just single contrast, that lining would be so thick on the walls of the large intestine that you wouldn't visualize the inside properly. You're just going to see the outside walls, essentially, because of the way that it's going to coat the entire large intestine. So with that being said, the most preferred method overall is the double contrast. In fact, in my experience, single contrast is quite rare nowadays because the double contrast allows such a better overall visualization of that entire large intestine plus the inside of it. So that would be the preferred method, double contrast, and that does mean alongside the barium, they're also adding air into the colon. And very important as well, that barium enema bag is typically going to be on a suspension pole 30 inches above the table. That's very important. If we don't have that bag 30 inches above the table, that barium's not going to flow into the colon properly at all. In fact, it's not going to flow anywhere. It's just going to stay stagnant. It's not going to go inside the colon. The point of putting that bag 30 inches above the table is to allow gravity to work and allow that retrograde flow into the large intestine. If I had it too high, though, above 30 inches, that could be detrimental. And the reason for that is if I go above 30 inches, it's going to go too fast. It's going to flow through that colon way too fast, and I'm not going to get a good study. So 30 inches is the gold standard of the height you want that bag to be at. Also, the other way around, if I have that bag too low, or if I had it on the table or below the table, well, guess what's going to happen? Absolutely nothing. In fact, we actually take that bag and put it on the floor when the study has completed. Why? Because the way retrograde works, if that bag is on the floor, the barium comes back out of the patient. And we typically will drain that barium out of the patient at the conclusion of the study and then have them go to the bathroom so they don't make a huge mess, like what I encountered my wonderful first day as an x-ray tech. And that's your typical barium enema tips right there. These two on the left are what I would call not the ideal tips to use. This very thin one on the left here is a pediatric BE tip. It's a lot thinner, as you can see. It'll go into a pediatric rectum a lot easier. This one in the middle is what I call the cheap barium enema tip. I do not recommend using this kind of tip at all. It's quite terrible. It's not reliable, and it does not stay in. Neither does the one on the left, by the way. And here's the reason I really recommend the one on the right. If you're a technologist and you have this available to you, use these tips unless the doctor says otherwise. The reason that this is the superior tip is because right here at the top, you see this little plastic lining? That's the balloon. The balloon I told you guys about that was placed in that lady's rectum that got blown out on top of me. That balloon is inflated inside the rectum to keep it in place. So if a patient is pushing, because naturally people are going to push, they're going to push down and try to get that tip out, it's going to keep it in place a lot more securely. Versus if I was to use these other two on the left, I'm going to have to use a lot of tape. You have to tape that to the patient, which is very uncomfortable, not the most reliable. And the only other option besides tape would be actually hold that tip in place, which sometimes I've had to do for pediatrics because the doctor, like if it's a really premature baby that's very small and you have to use those smaller tips, you're going to hold that tip in place during the procedure. Not the easiest thing to do either. It can be quite messy. So if you have the option and the doctor's okay with it, always opt for this one on the right. This would be the one you would also use for double contrast studies, preferably because it's going to let that air flow in a lot better. That is the three most common types of tips you will see. Sometimes they'll be colored pink instead of blue like this. In fact, I think the ones Harris Health uses are actually pink. So it will be the same thing, but it'll be colored a little differently. All right, so the most common complication that can arise on a barium enema is damage to that rectal wall from improper use of a balloon catheter. How's that happen? Two ways: overinflation. In other words, the tech put way too much air in there, and there's a certain exact syringe size. I believe it's 30 mils, if I'm recalling that correctly. 30 milliliter syringe. It is, because it says 30 to 90 down there. 30 milliliter syringe. And even though it gives you a range of 30 to 90, you typically don't want to go above 30 because that's where you're going to risk damaging the inside of that rectal wall. You can see how big that balloon gets. It actually gets a lot bigger than that picture. If you go really high on that balloon, you're going to risk damaging those intestinal walls. Plus, if they were to snag that tip and have it ripped out, that could cause damage as well. It's all about that proper use, making sure the patient's cooperating, make sure they're not pushing down, trying to push that tip out like what happened to me. But we do use that balloon to keep it in place. That's the preferred method. We just have to make sure we're doing it properly, that we're not overinflating that balloon, and of course that nothing's pulling that balloon out of the patient. And very important, of course, guys, when we finish this procedure, so not only do you actually insert these tips in the patients, guys, yes, you insert the tips, but you also have to remove the tips. And it's very important that when that study is done, you use that syringe to pull the air out of the tip before you pull the tip out. Because if you go over there and start yanking on that thing and that balloon's still inflated, that patient's going to be screaming to high heaven at you and say, "You're killing me, you're ripping my insides out." And you can rip some insides out if you're not careful with that. So deflate that balloon before you remove that tip. Very important. And you also see here, I didn't mention this, another reason that tip is inflated, it's going to prevent that barium from leaking out as much. It's going to keep like a seal. It's going to create an actual seal so that that does not flow back out. It's going to stay within the colon. Okay, so for enema tip insertion, this is one of your required competencies, by the way, guys. Everyone here has to do a successful enema tip insertion. Yes, yes, you do. I see your faces. Yes, you do. It is not as bad as it looks. I promise you, it really is not. So, of course, it goes without saying, guys, when you are inserting a rectal tip, communication is the number one ally to you. You've got to communicate clearly, effectively, and properly to the patients. We've been talking about communication since day one. This obviously is a big deal. Don't be one of those techs that doesn't give a care, walks up to that patient and just jams that thing in there. Yes, that has happened, and I've seen that happen. Don't just walk up there and stick that tip in a patient. Obviously improper, obviously not ethical, obviously you're not going to be on that patient's best side either, at all. Clear communication. Sir or ma'am, we are going to be inserting a rectal tip into your rectum. It is very important that you relax, You take big, deep breaths, and you try not to push. I'm going to be applying lubricant to the enema tip. I'm going to apply lubricant to your anus. Be very clear where you're putting it. Say what you're doing when you're doing it. Ma'am, I am now applying, ma'am or sir, I'm applying lubricant to your anus right now to lubricate the area. I am also lubricating the enema tip. Are you ready? I need you to take deep, controlled breaths. We are inserting the tip. Keep breathing. Keep breathing. You're doing great. Keep breathing. Keep breathing. It's in. You did an awesome job. Assure those patients patiently, effectively. It really makes a difference, even if you think it is not. And sometimes you're going to get very vocal patients. Obviously, doing any inserting in that area can be very painful for some people, very uncomfortable, but it's all about how you are effectively communicating. Ma'am or sir, the tip is in. I'm now inflating a balloon. You're going to feel a little pressure. So you're not going to surprise them. You're going to feel some pressure right now. Keep relaxing. Keep breathing. You're doing great. You're doing great. You're doing an awesome job. You're going to get through this. Use those comforting words. It really does work. It really is effective. And of course, guys, without saying it, please wear gloves. Don't do this with your bare hands. It can be a very messy procedure. Very important to drain that air from the tubing before you remove it, like I just said. Very important to lubricate that enema tip. That's a big point, guys. Don't ever try to insert one of these things without lubricating the tip. You're going to have a bad time. You're just going to have a bad time. And never, ever, ever, ever force the tip. You can cause a lot of damage to a patient that way. And some people get really tense. They bear down, they contract, and you can't get the tip in. At that point, pull back. Say, sir, ma'am, I need you to relax. We're going to start over. Take some big, deep breaths. Let me know when you're ready. We're going to try again. Don't get mad like I've seen some techs just force that thing in there. That can cause obvious damage to your patient. Be careful. Communicate. Start over if you need to. Be patient. Even if you're in a hurry, be patient. It can be very tough. Imagine if that was you on the table. Imagine if that's one of your family members on the table. Always be thinking about that. I didn't put it on the instructions here, but I believe we mentioned it earlier, guys. It's important that you have the patient in the Sims position, which is what's demonstrated on the right side of that picture there. The Sims position to properly insert that tip. That's going to naturally relax what we call the anal sphincter, which is the opening of the anus. Anal sphincter will relax more naturally in the Sims position to allow that tip to be proceeded in a lot easier. And of course, for the enema tip insertion, guys, we do got to make sure it goes into a certain area. One thing that people make a lot of mistakes with is that they will only put the very, very tip of that tip into the rectum. They're not going to advance it far enough. And that causes a big danger of the tip just flying right out, especially when we start adding the barium, because adding the barium does increase the pressure inside the colon. So we do want to direct the tip 1 to 1.5 inches towards the umbilicus. The umbilicus is this anterior wall of the rectum right here on this right picture. And once you insert the tip, you're going to advance it superiorly and slightly anteriorly. That's to direct it towards that umbilicus area. And the total insertion should not exceed 4 inches. And you'll learn how to do that. You'll know how to judge that. And that's really important that you want to be right about at that 4 inches. Otherwise, you're going to risk that tip just flying out when the procedure starts. Then you got a mess on your hands, and you got a grumpy radiologist because you just messed the whole study up. They're going to blame you for it. They're not going to blame the patient for it. Okay, and I said this earlier, most of the bags that you use, those barium enema bags, are going to hold 3,000 milliliters. That is the amount that we typically fill it to. Some cases may need the full amount. Some may not. Most do not need the entire 3,000 milliliters, but some do call for that. It depends on the patient. It depends on the size of their large intestine, because every large intestine is made differently. Some need more than others, but you're never going to go beyond that 3,000 milliliters. It's typically prepared using warm or cold water. The most common is room temperature water. That's something where you got to communicate with the radiologist as well. You need to ask your radiologist beforehand, do you want cold or warm water? Because depending on what they're looking at, they may ask for a different temperature. Now, please do not ever, you see warm, do not ever put hot water in there, that has happened before. If you put hot water in that bag and you start administering that barium, you'll have a patient screaming at the top of their lungs. That's going to be very painful, having hot water go through the colon. It needs to be warm room temperature or cold water specifically. Never use hot water. And then, like we said before, you're going to put that bag at 24 to 30 inches, never beyond 30 inches, and never below 24 inches to get that proper flow. That's what that bag looks like right there, guys, on the picture. It's going to be literally filled with that barium hanging on a pole, that 24 to 30 inch margin. So we get that nice retrograde flow through the colon to light up everything we need to see very nicely.
Mr. Donahue, I have a question.
Yeah.
Is this the same as whenever they make the patient swallow the barium enema and they look at their colon as well? Or is this?
So they're never going to have them swallow barium for a barium enema. The only procedures that we're going to have them swallow barium would be for an esophagus, stomach, upper GI, or small bowel. Barium enema will always be done rectally in that reverse retrograde fashion. And that's a great point to bring up. We will never have a patient drink barium for a barium enema. It's always done in reverse through the rectum. That's the only way it's ever done, period. And does anybody know the reason for that? There's a very specific reason for that, actually. Let's use your critical thinking skills for a second. Why would we never have a patient drink barium to do a barium enema?
Maybe it's thicker, so it can possibly be aspirated and cause breathing problems. No, I'm throwing spitball at it.
No, it's good guess, but not exactly. So go ahead, Betty.
I thought because they wanted it to go through the rectum, like they to make sure it goes to the cecum, and if it starts backward, when like it go like from the ascending to descending, but they want it backwards, right?
Sort of. Pretty good answer. But the main reason you would never do a barium enema via swallowing is because the way the barium is going to coat the internal organs, the stomach and the small intestine would have barium in them, and it's going to cover up the large intestine, and we're not going to see it clear enough. When we do the reverse method, we're only lining up the large intestine, and we get a much clearer view of it. If we did it through swallowing, there's going to be a lot of anatomy with barium on it, and it's going to actually hamper the study. It's going to mess up the study because we can't clearly see the large intestine due to the way the organs lie on top of each other. It would not give us a good picture overall. That's the main reason, because of the superimposition of all the internal organs. Now, also, you did bring up a point, Betty. One of the other reasons would be the different. I'm sorry, Jonathan. One of you guys did about the consistencies of the barium is going to affect it as well, because we can't drink that thinner barium that we use on the barium enema. It's not going to work properly. That would be another reason, but the primary reason is the fact that those organs are superimposed. It's going to cover up the anatomy. You're not going to get a good diagnostic study overall. Okay, and that's what your double versus single contrast study would look like, guys. On the right is going to be a single contrast. On the left is a double contrast, and this kind of shows you what I was talking about. Single contrast, we can let me start over again. I can't talk this morning. We can kind of only see the outside walls of that large intestine. Versus if we look here on the left, with the air applied, we see our barium, but we also see the inside of that large intestine. So if a patient did have polyps or lesions or some other kind of pathology, I'm going to see a lot clearer on this double contrast study versus this single contrast study. So like I said, the single contrast is pretty much being phased out. It's an old school way. Double contrast is here to stay. That's going to be the most used method overall. And you can clearly see, as far as quality goes, why that double contrast would be chosen over the single contrast. By the way, just for fun, does anybody know what projection this is on the left?
It looks like a left lateral decubitus.
Very, very good. Very good. That made my morning that you got that right. Good job. How do you know that's a left lateral decubitus, Aurora?
I can see how
like the lines on the descending colon, I guess you can see.
Yeah, you see the straight lines. This is
The
actually
straight lines.
right.
So to me, that will be like I don't know how to explain it, but that's how I can tell it's a low lateral decubitus. I don't know if it's like the fluid.
You are correct. That patient is laying on their left side, and we know that because of these straight lines going across. This film's been turned upside, like it's turned right side up. Typically, it would hang on its side, like you guys remember with the cubes. If you remember with the cubes, if it's fluid or air, you see those straight lines, and we can see that the barium is going down towards the left side. We have the right side marked up. Therefore, this is a left lateral decube. Very good. Very good. Okay, so like I said, that is still getting widespread popularity. And I would actually go further and say it's become the gold standard for all our barium enemas. It's going to be used mostly for polyps if a patient cannot afford a colonoscopy, even though colonoscopies are becoming more affordable for patients overall. And do keep in mind, when we're looking at an actual radiograph, the barium will always be represented by the white area, which is what we call the positive agent, versus the air is going to be more black, which we call the negative agent. So barium is a positive agent and it always looks white. Air is a negative agent and it always looks black on our fluoro X-ray images.
I have a question.
Yeah.
So after the contrast, do they give them any fluids to just wash up the intestine?
So they won't. If you remember what I said though, when the study is over, they're going to put the bag on the floor, the barium bag, and they're going to let that barium drain out for like 5 minutes as much as possible. At that point, you would direct the patient to the restroom and tell them to just sit there and try to use the restroom as much as they can. They're going to pass the rest of that out as well as they can. Other than that, they're instructed, and you would tell the patient this, by the way. We're actually going to get to that on one of these slides. You're going to tell the patient to drink a lot of fluids. They may notice that their stool is white or gray colored, which is normal. But other than just tell them to drink fluids, they can go about their normal day life, eat, drink whatever they want. Just be aware that they need to have a lot of fluids so they don't have constipation, because barium can cause constipation if you're not hydrated properly, and if their stool may be gray or white for a few days. And that's what polyps look like, by the way, guys. If you don't know what a polyp looks like, that's the inside of an intestine with a camera. It's going to allow us to visualize those on that double contrast study a lot easier. Okay, so for a barium enema kit, it typically contains 4 main tools. There's going to be the enema tip, the actual enema tube, the enema reservoir bag, which is where the barium actually goes. You pour that barium into there, and the balloon with an inflator. Now, sometimes you'll have these actual inflators like this. Most of the ones I use had a syringe that you applied the air, but sometimes you'll actually pump it in with this little balloon as well to inflate the balloon. Then you clamp it. You'll clamp it down to keep that balloon inflated. Also, real important, guys, I didn't mention this before. If you're ever helping a tech do this, and you will at some point, these bags, when you're hanging them and putting the barium in, is these little blue clips. Make sure you have these clips on the tube, because that's going to keep that barium from flowing all the way out of that tip. And the worst thing you can do is start pouring that barium into your bag, and it goes all the way through and starts making like a water fountain shooting out across the room. Clamp those tubes down before you put that barium in the bag, or you're going to have a big mess on your hands. The tech should tell you that, but in case they don't, make sure you're clipping that bag. So a few patient concerns, guys. Always keep that tip firmly in the rectum, very important. Help them relax those abdominal muscles to reduce the pressure. You do that by constantly telling them through the entire exam, take big, deep, controlled breaths. I know it's uncomfortable. Keep breathing with me. Keep breathing with me. In fact, in a lot of ways, guys, during this procedure, you're kind of like a personal trainer is always trying to keep you pumped up and motivated. You're kind of that person for that patient during the exam. It's going to be all right. You're going to be okay. I know it's uncomfortable. Look at me. Keep breathing. Relax. You got to keep them motivated and relaxed through that procedure, through your communication. And you're using that oral breathing to prevent those spasms and cramps as well, because barium can cause the abdomen to cramp up a lot. It can cause inflammation. If they have severe cramping After the procedure is done, we can give them what's called glucagon. Glucagon is a drug that's going to help them relax and help to relieve the cramping. And then, like I just said, guys, you're that motivator, you're that calming agent for them. Take their attention away from the enema. You know, if you're a really talkative person, talk to them about something, like ask them what their interests are. Ask them about a TV show, something, whatever. Anything you can do to distract them from that procedure, it's going to make it go a lot smoother, because it is a very uncomfortable procedure, as you can imagine. So use your imagination there. Some of us are more talkative than others. I always felt awkward because I'm a more introverted person, so I never knew what to talk about. But I would just keep telling them to relax, breathe, look at me, it's going to be okay. We're going to get through this, you're going to be okay. It's almost over, you're doing great. You just got a little further to go. Keep breathing. Keep them calm. Keep them calm. Keep them calm. Very important. All right, and I already said this before, guys, but when you remove that catheter, guys, please deflate the cuff, which is the balloon. Otherwise, you're going to have a lot of pain. You're going to possibly cause damage to that intestinal wall. Deflate the cuff, and make sure you clearly give those post-examination instructions. And that, once again, is drink a lot of fluids, and your stool may be white or ashen colored for a few days. Ashen colored means gray, white or gray for a few days. It's totally normal. And I'll often tell them as well, you may have some constipation. If you're constipated, drink lots of fluids. It's going to help relieve that constipation, but it is normal. It's totally normal. So that's what I just said there, guys. Increase that fluid intake and fiber sometimes for a few days after that exam to eliminate the rest of that barium. Make sure they know that stool will be miscolored for a few days, and that they do need to defecate as much as possible to eliminate the rest of that barium from the body. You don't want to keep that inside the body. Barium will start to harden, and it'll cause more constipation overall for that patient. Okay, so one other type that you may see, guys, is what we call a colostomy. A person with a colostomy bag will have barium enema procedures as well. The four main reasons we would have a person with a colostomy bag do a barium enema would be for proper healing of that stoma. Stoma, by the way, is the exposed bowel on the surface of the abdomen. In case you don't know, guys, people with colostomy bags, it's because their colon is not working properly. A lot of these people have had a portion of their colon removed due to cancer or something else, and they can't defecate normally. So they'll actually have what's called a stoma, which is exposed bowel on the surface of the abdomen, and they will defecate through that stoma into an actual bag. A lot of patients come in with those bags, and then we'll have to remove that bag and put the tip into the stoma to do the barium enema. One of the other reasons we might do this exam is for obstruction, leakage, and to perform a pre-surgical evaluation if they have to have additional surgery on their large intestine. So don't let that throw you off. Sometimes we will do barium enemas on patients with these stomas. It can be very, very weird, very strange if you've never seen that before, because the weirdest part is a lot of these people, they don't know when they're defecating. They can't feel it because they don't have the typical way of defecating that a normal person would, and it just comes out. Feces will just come out of the stoma. So if you're with one of these patients, you're setting up, and they just start defecating through that stoma, don't react, be calm. They can be very embarrassing for them and for you. It can be messy. Keep the poker face on, help them clean it up, continue with what you're doing. And that's what it's going to look like right there, guys. It's an actual piece of exposed bowel, and we would actually insert that tip through that stoma. There's going to be a specialized tip, by the way, that we use for that. We have actual colostomy tips that we use. They're a little bit smaller, so they can go in that opening. A lot of them will have a dressing or a drainage pouch. That pouch, you need to make sure you remove it. Be careful with that pouch because it often contains a lot of fecal material. You don't want to spill it everywhere. And like I just said, you're going to use an actual specialized colostomy tip for that stoma insertion. And then last but not least, the only other kind of barium enema procedure you may see, especially in the world of pediatrics, I talked a little bit about this last semester, is the intussusception, which is when that intestinal wall folds upon itself. It's done very similar to your barium enema. The only difference is we're going to put a tip into the patient. We're going to set up, and we're going to use air. We're going to pump air into the patient's colon to hopefully open up that blockage. The pressure from the air will open up that blockage hopefully the first time. By the way, the only contrast we're going to use is air to start. If the air fails for an intussusception, we would go to a typical barium enema where we use actual barium liquid with the hopes that that might open up that intestinal blockage. If that fails, then the patient would need to go to surgery. So they're going to use air first, barium second, and then if none of those work, they'll actually go to surgery. They'll have to open up the patient's abdomen and unfold that intestine by hand. And that would be a last resort. And this is going to mostly present on pediatrics, like I said before. Every once in a while, it can happen to an adult, but it's very rare. If you ever go work in pediatrics, if one of you guys ever want to go work at Texas Children's, you'll do one of these at least once a night. They come in, for some reason, they always come in the middle of the night. I worked night shift for many years, and we would always do one of these at least once a night. Very, very for young babies and pediatrics, it happens quite. But the good news is, most of the time, using that air has a 9 out of 10 success rate. It's a very high success rate. Works very well. And you'll actually be able to see that intestine pop open, which is pretty cool. You'll be watching it on the fluoro. That intestine actually pops open when you start pumping that air in with that pressure. Pretty cool to watch. Pretty cool to watch. And that is the end of our non-aseptic chapter, everybody. Very short chapter. Not a ton of information. So are there any questions on the non-aseptic chapter? Any questions you have? Now's your time. Okay, so we will have an exam on Monday for non-aseptic techniques. Like I said, it's a very short chapter, not a ton of information. This will be a shorter test overall, either 30 or 40 questions. It won't be the full 50. Much shorter test. Pay close attention to the information. Pretty much everything we talked about has a very strong chance of showing up because we did not go over a ton of new information. If you have any other questions on it, though, please let me know. I will send you the rest of the PowerPoint. And that will do it for class today, guys. I'll let you guys get out about 15 minutes early. Go study for your image review exam that's coming up real soon. If you have any questions on that, please let me know. Other than that, I will see you guys in a couple hours.